Heading faster, I guess.
So perhaps you sit up the table.
Really early.
That's what I've been trying to driving.
Yeah. I've heard some, like,
That
I
means
really
that
like sitting there, where, like, the view of this. And then.
Oh, hi. We're ready to start. Can you guys hear us?
No, I was.
We get more time to
I don't think it's.
Yeah.
Okay.
Give a thumbs up or something.
Yeah, that's what I think I'm gonna end up doing, because I just get home very tired.
Can you guys chat something if you guys can hear us?
Oh, you studied today. Oh, that's great. Good. Yeah, it's good. If you remember, it's a good method to like remembering what you were talking about. Yeah. That's great.
Sorry, buddy, I just saw the.
Well, you need to.
It's already here.
Email Ivan and Casey. I'm using
Even if they don't, it can start, because we are already recording it.
Yeah.
They might be able to see.
To start.
And I've been using it quite a lot too. Look for if I have a certificate or something, and I don't know.
Okay, guys, we'll start the conference. It's 12:30. Dr. Malone is presenting on hypertensive emergency and urgency. I mean, yeah. I mean, most of the ions are here, but yeah, most of the ions are here. Yeah.
Okay, all right. So I'm gonna start. So today, hi everybody. If you don't know me, my
Can you stand up?
Yeah.
Or is that difficult for you? Right?
the whole time or just
Yeah. While you're talking, you should stand.
okay.
If possible. If
Yeah, the
it's
whole time maybe.
disturbing for you, then that's okay. I understand.
Okay. I'll try stand for a bit and then I'll probably sit
Yeah,
down after
exactly.
that. Yeah. So my name is Dr. Malone. If you don't know my name, today we're gonna talk about hypertensive emergency versus urgency. Hopefully it's a narrow enough topic. So definitions, hypertensive emergency versus urgency. So essentially they're SVP greater than 180 or diastolic greater than 120. The difference is that if you have emergency, you have evidence of acute organ damage, and then if you don't have or emergency, you would have without evidence of target organ damage. That's like the main difference, which I highlighted here. But the blood pressure parameters are kind of similar. And then there is an update to the guidelines. So most of this PowerPoint is from the AHA 2025 guidelines. There's also a statement coming out in 2024. Essentially, they changed this term. Used to be hypertensive urgency. Now we're calling it severe hypertension without target organ damage, essentially kind of spelling out what it is. We used to call it hypertensive urgency, and you may still see that in the notes. And then they also recommended this term called asymptomatic markedly elevated blood pressure as well, to kind of indicate that we do not need to aggressively really treat this when it's hypertensive urgency versus hypertensive emergency, which we'll talk about that you will need to aggressively treat. And then, so this is a kind of a typical organs that will affect with hypertensive emergency. So there is a mnemonic here called BARC. I just put a dog meme here to help you remember. I have a thing with dog memes, so and then so BARC essentially is brain, arteries, retina, kidney, and heart. So typical brain getting affected by the hypertensive emergency include encephalopathy. So you may see some alternative status, press, intracranial hemorrhage, acute ischemic stroke, arteries. So the big ones that we want to look out for is acute aortic dissection. So later we'll talk about like when you want to suspect that, or less commonly penetrating aortic ulcer. Retina-wise, retinal hemorrhages could be seen, papilledema could be seen. And then kidney-wise, the most common is AKI. And then heart-wise, the most common is flash pulmonary edema or acute heart failure secondary to the hypertensive emergency, or ACS, acute coronary syndrome secondary to that, or if they already have heart failure, now it's decompensated heart failure. And then initial evaluation and workup. So step one, we should always confirm the blood pressure that is real. So the proper technique here is we want to make sure the cuff size is correct. If you're having a smaller size woman, don't use a large cuff. That would not be accurate, or vice versa. Patient needs ideally should be seated and rested. And then sometimes you can repeat the measurement after you ask them to sit down for another 30 minutes and then rest for a bit and then recheck. Also, you want to measure both arms as well to see if there's a difference. For step 2, then we'll see if there's any target organ damage. So then now you're trying to see whether it's emergency or urgency. And then so that you can first get a thorough history. So first you can figure out whether this hypertension is chronic or this patient has no idea they have hypertension at all. If they are taking their current medication, because a lot of times we see in this hospital particularly is due to medication noncompliance. Adherence, we ask for that. And then you can ask them if they ever measure their blood pressure at home, whether that's been elevated or that's been normal, or if they measure the blood pressure at home at all. You do a good physical exam, so you check your bilateral pedal pulses, also check your wrist as well, pulses. Cardiac and pulmonary auscultation, you're trying to hear for the pulmonary edema, if there is any, or there's any abnormal murmurs that you can hear. You can do a fundoscopic exam to look for the retinal hemorrhage, and then neurologic exam, we're looking for any encephalopathy, of course. You can also, maybe there's some other further neurologic abnormalities as well. Some diagnostic investigations, the first basic labs, we're going to get a BMP to look for renal function, to look for if there's any AKI. Electrolytes to see if there's any electrolyte imbalance. On CBC here, we're looking for if there's any hemolytic anemia that could happen with hypertensive emergency as well. When your blood pressure gets way too high, then it mechanically essentially shears the blood cells. And then you can get a UA to look for proteinuria, hematuria. We'll get a baseline EKG to look for if there's any ACS in there or any new EKG changes. You get troponin, you get a chest radiograph. There you're looking for if there's any pulmonary edema, like we said before, for the most part. And if you suspect there is thrombotic microangiopathy, which we said is due to elevated blood pressure that's actually mechanically shearing the cells, you can get your hemolysis labs, which are listed here. Some additional imaging as indicated. So if the patient is encephalopathic, you can consider doing a CT head to make sure there's no acute stroke. If you're concerned about aortic dissection, which later we'll talk about when to suspect that, you can get a CT angiography to look for that. If you're suspecting new onset heart failure or worsening heart failure, you can get an echo. So these are some of the common things that we get. Okay, so I'm gonna sit down. So when to suspect aortic dissection. So I think this comes up a lot. Like a lot of times people are like, I wonder if this is aortic dissection. So there's actually a score that is recommended by the EACTS or the STS. Essentially, there are the thoracic surgeon societies, the European and the American. So then their guidelines, there is a score called the ADDRS score. So they recommend we combine the ADDRS score plus D-dimer in order to whether to say we should suspect aortic dissection or not. You can find this in the MedCalc. So I took it directly from MedCalc. For the ADDRS score. So essentially you would say whether there's any high-risk condition, which include Marfan syndrome, any family history of aortic disease, any known aortic valve disease, recent aortic manipulation, they have procedure done, or a known thoracic aortic aneurysm. So any of those pre-existing conditions that will put them as high risk, that'll give them 1 point. And then the second one, we'll see if it is any high-risk pain feature. So this should come from your HPI. They should, textbook-wise, they should describe a chest pain that's radiating to the back. You may not get that, but essentially if they have any chest, back, or abdominal pain described as abrupt onset, severe intensity, I think the more important here is more the timing. They should be abrupt, and then they should be pretty severe. And then they could describe it as ripping or tearing, that depends. So if they have a high-risk pain feature, that also give them 1 point, so you plus 1 point there. The third one here is from your physical exam, any high-risk exam feature. So if you found any perfusion deficit, if there's any pulse deficit, and then, or if there's systolic blood pressure differential on different arms, or if they're focal neurological deficit plus pain, any of those, or if they have a new murmur that you heard that was not there before, or if they're already in hypotension or shock, any of those high-risk exam feature also get 1 point. So essentially, they're saying you should also get a D-dimer, and D-dimer, the threshold here is 500. So if it's 0, then we can proceed to the D-dimer testing and then combine those to assess. If the D-dimer is less than 500, then we can consider stopping the dissection workup. Or if D-dimer is greater than 500, even if you have 0 point, you can still consider getting a CTA. But if they have a high, like 1 point here, you should consider getting a CTA. And then, but if you have 0 point, you should combine that with D-dimer. So this is an algorithm that's from the 2025 AHA for hypertensive emergency urgency. We're going to kind of dive down in different aspects of this as well, but I want to give this at the beginning, and I'll also give this at the end, trying to summarize it essentially. So if we kind of go through this briefly, at the beginning, we're assessing, so if your blood pressure meet those criteria, then we assess whether there is acute target organ damage. If yes, then we're saying that's emergency. If no, then now we're calling it severe hypertension instead of urgency. And if it's emergency, technically per guidelines, we should admit them to ICU, even though you may see some hypertensive emergency here being managed on the floor. But if you're answering like a question from MCSAP, the answer should be admit to ICU if you think it's really hypertensive emergency. And then the only two conditions here that they have clear parameters of I guess not clear parameters, that they have different parameters compared to the typical hypertensive emergency is aortic dissection and pheochromocytosis, crisis. So the other ones, essentially, they listed that there's not enough RCT data to really differentiate them to put a different parameter for those particular conditions. That's why they only listed these two. So if you're suspecting aortic dissection, you should be reducing the blood pressure SBP to less than 120. And then if you're suspecting pheochromocytoma crisis, you should reduce it to less than 140 in the first hour. And we can see here it's green. So when it's green, we're saying it's category 1, which is strongly recommended. And then if there are none of these two, then you essentially go to the no on the right. For all of the others, hypertensive emergency, we want to reduce SBP by 25% in the first hour, and then to 160 over 100 over the next 6 hours, and to normal in the next 24 to 48 hours. So that's for hypertensive emergency. And then if we're saying no target organ damage, now we're going to the right, then we're saying this is severe hypertension. Depending on whether this patient is seen in the ED or in the outpatient setting, if they're seen in the ED, then first we want to evaluate whether we want to inpatiently treat this patient or we can outpatient just follow up and discharge this patient straight from the ED. So they're recommending to make that decision. That should be depending on the indication other than the blood pressure itself. So the guidelines recommend to avoid IV blood pressure medication for severe hypertension or hypertensive urgency. Even though you may see a lot of ED already give the patients for hypertensive urgency IV medication by the time that you get them. And then even though the guidelines actually recommend to avoid giving IV blood pressure medication for just hypertensive urgency. And what they do recommend is to resume or intensify their PO medication and do close outpatient follow-up. And then if you see this in the outpatient setting, if they have no signs of target organ damage, or if you're not suspecting target organ damage, they're recommending no need to refer to ED. Even though sometimes in the clinic you see patients that are like 220 or over 120, and they say, okay, it's always like this, but I have no symptoms. So you can just sort of decide for yourself whether you suspect target organ damage. If there's any abnormal history, physical, ROS, then you can make a decision whether you need to refer them to the ED.
Just a tiny little caveat. When you say, which is correct, restart the medication or intensify the medication, be sure that the patient really took the medication. Because most patients have 40 milligrams lisinopril or blood pressures under control, add on 10 milligrams of Norvas, add on 25 of HGTC, and the patient neither has taken 1, 2, or 3. If you just restart, quote unquote, restart all of them, they will drop. So do not restart, quote unquote, if you are not 100% sure that the patient really took it before. Go slower because it's an emergency, exactly what you're pointing out.
Yeah, for sure. Yeah, so right. So a lot of patients that we see, especially in the clinic, that if you're already suspecting like some medical noncompliance, then you want to figure out whether they're actually taking it or not. So this is like an overview, and next we'll kind of break down. So hypertensive emergency. First, there is a very high in-hospital mortality rate, about 10% with a 1-year cardiovascular morbidity mortality rate of 20% to 30%. 10% with a 1-year cardiovascular morbidity and a 20 to 30% mortality rate. So the mortality rate is actually quite high for these patients, as you can see. Our therapeutic goal is to minimize further target organ damage because we said they're already target organ damage to start with. So the goal is to rapid initiation of now IV, ideally hypertensive treatment. And then, so they're recommending some short-acting titratable antihypertensive agents is usually preferable because as you can imagine, if we do some type of titratable medication, we can easier to get them to goal. And I put the references in the lower